Hello everybody, welcome to your Respiratory Emergencies lecture. Today we're going to be talking about those medical emergencies that can happen to your respiratory system. If you haven't done the reading for this week, no worries, follow along with me on these next slides as we go. Next, we're going to talk about the basic anatomy and physiology of the lungs and the respiratory system, and some complications that can arise to deal with some respiratory emergencies. So the lungs are those spongy pinkish organs that sit right in the middle of your chest. The right lung is made up of 3 lobes, and the left lung is going to be made up of only 2 lobes to make room for your heart. The lungs begin at the bottom of your trachea, or your windpipe. The trachea is going to be that tube that carries the air in and out of your lungs. There are 2 bronchi airways that connect the trachea to the lungs that basically forms an upside down Y. From there, the bronchi break down into smaller tubes called bronchioles, and from there, these tiny tubes stretch out into every part of your lung. You have almost 30,000 bronchioles in each lung. At the end of each of these, there's a cluster of these small air sacs called alveoli. They look like tiny little grape bunches or very tiny balloons, and there's almost 600 million alveoli in your lungs. When it comes to the different parts of the respiratory system, we can break the respiratory system up into 2 things, the upper and lower. The upper respiratory tract includes the mouth and the nose, the nasal cavity, down to the throat and down to the voice box. The lower respiratory system, or tract, is made up of the lungs, the trachea, the bronchi, the bronchioles, and the alveoli. The diaphragm, which is that big muscle below the lungs, and the ribs that surround the lungs, help the respiratory system and your lungs to expand and contract to help you breathe. So when we breathe, the air is going to be entering our mouth and nose and travels all the way down our trachea, bronchi, bronchioles, down into those alveoli, and all those alveoli or alveolus is covered by a net of tiny blood vessels called capillaries. And here is where there's going to be an oxygen and carbon dioxide exchange. So the heart is going to be extending that deoxygenated blood to the lungs. Here it is carrying that carbon dioxide rather than the oxygen. As that blood passes through those tiny thin capillaries, they get oxygen from the alveoli. They return the carbon dioxide through those thin walls to the alveoli. The oxygen-rich blood then is going to be sent back to your heart where it's pumped to your entire body. The carbon dioxide is breathed out of your lungs and through your nose and mouth. Let's talk about the different types of respiratory emergencies, starting with hyperventilation. So hyperventilation is basically an increase of your respiratory rate causing respiratory alkalosis, basically meaning not enough CO2. It's usually brought on by some sort of anxiety, pain, cold water immersion, or voluntary. This person is going to have that suffocating sensation. They may be quite dizzy. They may have a rapid heart rate or respiratory rate. They may have some chest pain. Facial spasms are common in their hands and feet as well, or they may lose responsiveness. The best way to treat these patients is to help calm them down, to assist with that breathing. As you can see in the photo here, a paper bag also works. You want to help assist them in slowing that breath down. However, if they're unable to slow their breathing down, that may mean deems for evacuation. When we breathe normally, there's going to be a healthy balance of oxygen and carbon dioxide in our inhalations and exhalations. However, when we disrupt this and when we start to hyperventilate by exhaling more than you inhale, this causes that rapid reduction in carbon dioxide in that body. That low carbon dioxide then leads to that narrowing of those blood vessels that supply that blood to the brain. This reduction in that blood supply brings that lightheadedness and tingling in those fingers sensations, especially when it comes to the signs and symptoms of hyperventilation. We want to note that severe hyperventilation can also lead to a loss of consciousness due to this physiological effect. And also, you want to note that if this does happen or if they are unable to slow their breathing, we are rapidly evacuating this patient. Next, we're going to talk about one of the most serious and life-threatening respiratory emergencies, and that is a pulmonary embolism. So a pulmonary embolism is similar to that of a heart attack. You can call it a lung attack. It is basically a blockage of one of our pulmonary arteries in our lungs. Usually, this embolism or this clot is caused by blood clots that travel from deep in our legs. These are incredibly life-threatening and serious, which prompt quick treatment and rapid evacuation to reduce the risk of death in this patient. The signs and symptoms can vary due to how much of your lung is involved and the size of that clot, or whether you have any underlying lung or heart disease. But the basic signs and symptoms include that sudden onset of sharp chest pain. It's usually accompanied by some sort of respiratory distress or shortness of breath. That patient may be coughing, possibly have some bloody sputum in their cough. You're going to be noticing some vital signs of shock. And then you're going to want to gather that history of that patient to make sure there has been no prolonged sort of bed rest, they're not a heavy smoker, no recent surgeries, no long bone fractures in their legs. Sometimes birth controls can attribute to clots in the legs and the body. Dehydration or even high altitude can be a risk factor. You're going to want to seek immediate medical attention, especially if this patient is experiencing some sort of unexplained shortness of breath, sudden chest pain, or cough that produces that bloody sputum. It can definitely mask itself with those signs and symptoms of a heart attack, but you want to definitely differentiate between the two. With a heart attack, you're going to be noticing more strong signs and symptoms of chest pain, breathing discomfort, of fullness, tightness in the chest, some sort of history of angina, coronary artery disease, etc. With a pulmonary embolism, however, you're going to want to get that history of the patient, and that OPQRS-T stage is crucially vital to understand this chief complaint and see if it was completely sudden, if they're having a hard time breathing, if there's any sort of bloody sputum in their cough. You're also going to want an understanding of what this patient has just been doing. Have they been sitting in bed for a long time? This can happen especially on long haul flights when that person has been sitting in a position for too long, or even if they have just suffered some sort of femur fracture or long bone fracture in the leg that may be causing some sort of clot to form there that has escaped and unfortunately gotten stuck in their lungs. Asthma is going to be one of the more common chronic lung conditions you may encounter. It is characterized by a reactive airway disease that is commonly occurs from constricted bronchi. There's usually also an increased mucus production in that area as well. Asthma attacks happen, however, when those airways start to tighten and narrow, slowing down that airflow. The lungs then become swollen and inflamed. Asthma attacks can usually be triggered by some sort of allergen, pollution, asthma-induced exercise, or any other respiratory illness, or even cold air. We want to note that these can be mild, moderate, and even severe. So when we talk about that mild to moderate stage, I want to talk about some of those signs and symptoms. So it's going to be accompanied by some sort of chest tightness, some sort of wheezing, shortness of breath, increased heart rate and respiratory rate, and usually fatigue. The patient is probably going to have some sort of history of asthma and is going to understand what is happening to them. They may know what works best for them when they start having an asthma attack, but it's good to educate yourself as a first responder on some sort of the treatments that may be useful. So when it comes to a mild to moderate asthma attack, we want to make sure that we change the environment for this patient. We want to make sure that the patient is nice and hydrated and rested, and they're nice and warm. Maybe provide some humidified oxygen as well. We want to calm that patient down and coach them into normal breathing if possible. However, asthma attacks can progress into something more severe. Some signs and symptoms of a severe asthma attack include that shortness of breath while they're resting. You're going to notice some very diminished breath sounds, and they may be speaking in just one or two word clusters, whatever they can get out. They may start to feel very sleepy, and they may become cyanotic, so their skin is starting to turn blue. So that oxygen, because they're not breathing, is not getting to that main organ, that epidermis, and that is something very, very serious to note. With these, obviously, any shortness of breath at rest or any signs and symptoms of a severe asthma attack, we're going to rapidly evacuate this person to more advanced care. However, I do want to talk about some sort of medicine that most people use when they do have asthma, and this is going to be an inhaler, or basically albuterol. As first responders, we are never allowed to give this patient their albuterol or inhaler, but we can help assist them if it's necessary. So albuterol, or a metered dose inhaler, is basically a bronchodilator. So it's going to dilate those bronchi in the body. The dosage for this is 2 puffs every 4 hours and as needed. So the patient may need 4 to 8 puffs every 20 minutes, up to 4 hours if it's an acute severe episode. I want to note, however, shortness of breath at rest, if they are having a severe asthma attack, is a huge red flag to me as a first responder, and I'm going to try to get this patient to advanced care as fast as possible. If I am noticing that they are suffering a severe asthma attack, I can utilize and help them with this form of treatment of giving them 4 to 8 puffs every 20 minutes, up to 4 hours if it's a severe episode. However, if it's in that mild to moderate stage, they can get 2 puffs of that every 4 hours as needed. For this medicine to reach those lungs correctly, the patient needs to completely exhale fully. They're then going to place the inhaler in their mouth. On inhalation, they're going to release and press down on the albuterol, and they're going to make sure that none of that medicine is hitting their tongue. They want to make sure it's all going back down into their windpipe. Like I talked about in cardiac emergencies in medicine, we want to make sure before you assist or educate this patient that you are following those 5 rights. So for medication, so it has to be the right patient. You're going to check on their inhaler. It's going to be the right dose of albuterol. It's going to be the right drug. So if they're suffering an asthma attack, you're going to want to help administer albuterol. The right route is going to go in their mouth, and you're going to make sure that it's the right expiration so that the medicine has not expired. Next, we'll briefly talk about pneumonia, and this can be a severe complication of some sort of respiratory infection. It's basically an inflammation and accumulation of fluid within those alveolar spaces, those tiny spaces within the lungs. Some signs and symptoms of pneumonia is basically some sort of history of upper respiratory infection. There's going to be accompanied by some fever, sweating, chills. There's going to be a productive cough, so a constant cough with usually some sort of sputum. That patient is going to be having a hard time breathing, show shortness of breath. When they inspire, when they inhale, there's going to be some sort of pain. You may hear some wet lung sounds, and the patient may be very, very fatigued. Pneumonia can be bacterial or viral, and it's incredibly hard to treat or monitor in the field. So if you do suspect pneumonia, especially if you're 72 hours away from care, you're going to want to start thinking about evacuation. Depending on what type of pneumonia this is, you're going to want to evacuate this patient to more advanced care because they may need antibiotics, especially if it is a bacterial pneumonia. You can help get this patient to cough and breathe deeply to try to get some of that sputum out, and administer some sort of fever-reducing medications. Basically, all we can do for pneumonia is fight the symptoms. This may ring a familiar bell with the current crisis of the world right now. So with COVID-19 as a viral disease, this can definitely spread from the upper respiratory infection into that lower respiratory infection, causing viral pneumonia, which is a severely life-threatening disease. It is good to recognize these signs and symptoms of pneumonia so you can get access to the advanced care as quickly as possible to help save this patient. Finally, we're going to be talking about allergic reactions and how they can be related to a type of respiratory emergency. So allergic reactions are basically an excessive release of histamines within the body from the body's immune system in response to the presence of some sort of foreign allergen, such as a pollen, animal dander, foods, plant oils, insects, drugs, etc. You have all probably experienced some sort of allergic reaction, especially living in Bali, and it's usually probably been on the milder side. So when it comes to a mild allergic reaction, there's usually some sort of swelling near the injection site, near the stimulus of that response on the skin. The skin may be flushed or itchy. There may be hives produced like you see in this photo, and it's accompanied by absolutely no respiratory difficulty. Yes, there may be anxiety produced from an allergic reaction, but we want to differentiate the two between a mild reaction and a more severe reaction, especially when it comes to anaphylaxis. Treatments for these mild allergic reactions can be helped with the administration of oral antihistamines such as Benadryl, or even topical antihistamines. So this basically means that it can treat the pain and itching caused by these sort of insect bites, these cuts, these burns, any sort of allergies, these cold symptoms, etc. We want to definitely remove that patient from that allergen source. And we wanted to monitor for any sort of facial swelling or airway swelling that can lead to respiratory difficulty or anaphylaxis. Next, we're going to talk about those severe allergic reactions or an anaphylactic reaction. The reaction can occur within seconds or minutes of exposure to that type of allergen, and these can definitely be life-threatening. Many of you may have found out if you were severely allergic to something as a child and now may carry an EpiPen or an auto-injector pen. The most common sources of these anaphylactic reactions are usually to foods, insect stings, medications, and even latex. When you're exposed to an allergen and you are allergic to it, your immune system overreacts to this allergen by releasing chemicals that cause those allergy symptoms. Typically, those bothersome symptoms, like in that mild reaction, occur in one location of the body. However, if you are those people that are more susceptible to a more serious anaphylactic reaction, this reaction typically affects more than one part of the body at the same time. This is going to require immediate medical treatment and more advanced care, and hopefully the prompt use of an epinephrine auto-injector pen, and usually a trip to the emergency room. If it isn't treated right away in a prompt manner, anaphylaxis can usually be fatal and result in death. When we talk about anaphylaxis, anaphylactic shock is what I'm most referring to. So, as a result of your immune system releasing a ton of chemicals that flood the body, it can lead to the anaphylactic shock. When your body goes into this type of shock, your blood pressure suddenly drops and your airways start narrowing, possibly blocking that normal pattern of breathing. This patient is going to be really struggling to breathe. They may be quite dizzy from that lack of oxygen and quite confused because that oxygen is not getting to the brain. They may be feeling quite weak and they may be actually unconscious. Anaphylactic shock is extremely, extremely serious. It can start blocking your airways and prevent you from breathing, which can then in turn stop your heart. This is going to be due to that decrease in your blood pressure that prevents the heart from receiving enough oxygen. A lot of complications can occur, especially brain damage, cardiogenic shock, heart attacks, death, etc. I'm going to briefly talk about the use of an EpiPen. So if you do have some sort of anaphylactic allergic reaction, that patient usually is carrying some sort of epinephrine auto-injector or an EpiPen. And this is used at the first onset of your symptoms. An anaphylactic reaction is going to be a life threat to that A or B stage. So you're going to want to instantly understand what is happening to that patient and see if they do carry an EpiPen. We are going to be posting a video about how to help administer the use of an EpiPen, but I just want to go over it briefly in this lecture. EpiPens, or basically the use of adrenaline, which is what epinephrine is a short-acting treatment to an anaphylactic stage, and they're going to be a one-time use. So when you come across a patient that is having an anaphylactic reaction, they have an EpiPen, you've gone through those 5 rites, you realize that this is a life threat to A and B, you're going to be helping administer this EpiPen to the patient. One, you are not going to be using this yourself on the patient, but you're going to have that patient hold the EpiPen in their hand and self-administer it themselves. You can follow these simple steps on how to help administer an EpiPen to the patient. You're going to want to carefully remove that auto-injector from the tube that it's in. You're going to want to grip the barrel of the injector. You're not going to want to place any of your fingers on, or the patient's fingers, on either ends of the injector. You're going to want to make sure that the orange tip points downward. You're going to want to remove that blue safety release. You don't want to twist it or bend it. You're then going to firmly inject that orange tip of the injector into the middle part of the upper thigh, pushing it until it makes a clicking noise. You're going to hold it here for about 3 seconds, counting very slowly before you remove it from the thigh. You can have the patient or yourself massage that area gently for about 10 seconds. You're then going to want to seek immediate emergency medical care and get this patient in transport to more advanced care. The EpiPen is quite strong and can be administered through clothes, but sometimes this person may need a second dose. You cannot use the same EpiPen twice. They're going to need to have a new separate EpiPen. Again, like I said, these are temporary treatments to the cause at hand. So this patient may go back into anaphylactic shock, which is why seeking more advanced care is critically important.